Hello, and welcome to the Society of Skeletal Radiology's Resident Education Club webinar. My name is Laura Fayad, and I'm speaking to you from Johns Hopkins in Baltimore. And it's really a pleasure for me now to introduce our guest speaker, Dr. Blake Jones. I've known Blake since he was a stellar, outstanding resident at Johns Hopkins, and by way of background, he graduated from Notre Dame, magna cum laude, followed by an MD from Case Western. Then he went on to do his residency at Johns Hopkins, followed by Musculoskeletal Imaging Fellowship at Johns Hopkins. Currently, Dr. Jones is at the Medical College of Wisconsin as an assistant professor. And Dr. Jones has a few publications to his name on the topic of musculoskeletal tumor imaging, which you're going to hear about today. And most recently, he discussed some advanced topics in MSK tumor imaging, including such techniques as diffusion and DCE MRI, and most recently 3D imaging for musculoskeletal tumor imaging. So without further ado, let me introduce Dr. Blake Jones.
Thank you very much, Dr. Fayad. I, of course, owe much of what you said to your mentorship throughout the years. So thank you very much for that. So we'll get the slides here and we'll go ahead and get started. So, okay, so this evening, let me make sure I can control the screen. Excellent. So this evening, we're going to be talking about MSK tumor imaging, and I'm going to show you some cases that I hope will be educational, both from their standpoint of making the diagnosis, as well as using MRI to sort of go through the thought process of an MSK radiologist looking at a tumor case. All right, so our first case is a 52-year-old female with a lump. So hopefully you guys can log into the Poll Everywhere. The information, the link is up there at the top of the screen. If you go to that link, it lets you click. I see you've got some clicks coming in. But yeah, if you haven't been able to log in, that's the link up there at the top of the screen. If you're not familiar with Poll Everywhere, just go there and then you can answer the questions as we go along. And so I see we're obviously getting a number of little green dots coming down on that mass there. More interesting question then, as I think most people probably saw that right away. Go ahead and tell me what things you're considering in your differential diagnosis. That's a good one. Excellent. So I see a lot of things that I like that are coming in, and I'll give you my thoughts on next slide, but I really like, somebody has said, obviously sarcoma, definitely looking at that. Someone has said, people have said myxoid, cyst is certainly something you could consider. And then I like that we're mentioning some nerve tumors and even vascular tumors in there. So excellent work all. Let's see what's coming in now. I see. Okay. All right. So, just my thoughts looking at this case basically echo most of the things that you guys said. Still just in a couple slices here, I don't think we've 100% gone one way, benign or malignant. So in the benign category, definitely a nerve sheath tumor. One thing could be, some old hematoma trauma type of thing, although maybe the signal isn't the best for that, but certainly always something to consider when you see something focal in the muscle and the soft tissues. Clearly sarcoma, T2 hyperintense ones like myxoid, synovial sarcoma, extraskeletal myxoid chondrosarcoma, or a malignant peripheral nerve sheath tumor. So I'll give you a few more images here. Here we have a coronal T2 fat sat image. And here we have post-contrast images, both in the axial and coronal plane with fat suppression, illustrating some of the features of the mass that I hope will help you sort of narrow your differential. And to that point, there's a particular feature that these images are showing, and I put here the post-contrast image that's showing actually an additional suspicious feature of the mass. I see the dots coming on that little area of, you know, hypoenhancement or necrosis or whatever it is in the middle. That's a good one. And I see some more dots coming on that little tail that's going inferiorly. So that is excellent. So based on that information, before we talk about that further, let's take it to a vote. So I see our votes for a malignant lesion are creeping up and up. So I want to give you another image that, you know, this one, you guys may or may not be familiar with using this type of imaging to evaluate for this feature. But go ahead and, you know, see if you can identify what kind of image I'm showing you based on the caption here, which I've blown up there because you couldn't see the original one from the packs. And tell me whether this feature that I'm showing you is increasing or decreasing the likelihood that this lesion is malignant. So again, that's awesome. I see the you know, we're clearing 90% voting for increase the likelihood of malignancy, which is excellent. So so I want to kind of talk about some of those features that we talked about. So, you know, we kind of went over this. If something's T2 hyperintense, you know, it puts you into a particular category of lesions. Myxoid lesions, chondroid, nerve tumors are sort of prominent examples. Perilesional edema and enhancement are suspicious features in a lesion like this, in a soft tissue sarcoma especially, and one that you guys may or may not be familiar with, although guessing that since over 90% of people said that they thought that ADC image increased the likelihood of malignancy. I'm guessing at least some of you are. So when a lesion has an ADC value less than 1, that's suspicious for a soft tissue tumor to be more of an aggressive or malignant type of lesion. And this is defined, by the way, as the you look at the lesion and find an area that's visually the lowest value, and then you measure the ADC value, and it has to be in an area where the lesion is enhancing, because otherwise, you know, ADC has many confounders like susceptibility artifacts from hemorrhage or metal or various things like that, air. So it has to be an area where the lesion is enhancing, but nevertheless, that feature does help you decide that the lesion is more of an aggressive type lesion. Just a note about synovial sarcoma, since I mentioned it in our differential, just because I think it's a useful pearl for residents. Synovial sarcomas, despite their name, they occur near but not in joints, so keep that in mind. And this lesion, as I said, turned out to be a myxofibrosarcoma, which in particular is common in elderly people, a higher risk of local recurrence than there really is of metastases. And what I was alluding to, although certainly that little area of central necrosis was correct as something that it makes you think the lesion is suspicious, but this tail sign has been described in myxofibrosarcoma, and it's useful in other lesions as well. But in myxofibrosarcoma specifically, it connotes a higher risk of local recurrence. All right. We're going to pause for questions, right?
Right. Before you go on, Blake, there is a question. Is the low ADC value, does that increase your suspicion for malignancy because of hypercellularity in particular?
Yeah, I mean, as far as I know, I think that's the purported mechanism of that. You know, it sort of connotes the lesion as more cellular. You know, the reason that we say that is just empirically, you know, basically studies of when they took lesions and looked at the ADC values, and the ones that had the lower ADC value were, you know, more likely to be malignant. So it's more of an empirical finding, but, you know, that's one of the purported possible explanations for why that might be the case, as far as I know.
Okay, the other thing I wanted to comment on this case is that you have a soft tissue mass, and you pointed out that the perilesional contrast enhancement makes it a little bit more suspicious, but we can have soft tissue sarcomas without any perilesional enhancement. And in fact, when you do have perilesional contrast enhancement, it's most likely to be a high-grade tumor, much more likely to be a high-grade tumor than not. So not having contrast perilesional enhancement doesn't mean it's a benign lesion. Okay, any other questions? You can feel free to type them into the Q&A. All right, we'll go on.
All right, next case, 60-year-old male with abdominal pain, weight loss, and diarrhea. So it's an MSK conference. So I put an arrow on the finding for you, since it's the body finding. You can see the hypoattenuation in the pancreatic head and uncinate process, and sort of some upstream dilation of the pancreatic duct here. So obviously the suspicion is for pancreatic cancer. And then looking at the patient's hip, we have this lesion here during his initial staging. So vote for your differential diagnosis of this lesion. Sorry, what I'm asking actually is which one of these would you not include in your differential diagnosis? I apologize. Which one? I know that's not boards, you know, what you're supposed to do, but which one of these would you say is not, you know, not really in your differential based on the appearance? All right, awesome. So we have votes for some other stuff, some variety of votes. Giant cell tumors in the lead, and it seems to be creeping up here. So excellent. We'll talk more about all the answers at the end, as we did for the last one. So here's the CT appearance of the lesion. You know, the patient received a PET CT for staging of the pancreatic cancer. I direct your attention to the appearance of the lesion here on CT, as well as the appearance here on the FDG portion of the PET. So given what the PET showed, what do you think is going on here? So I see, obviously, we have a lot of votes for METs and metastases. I see a benign, and then we have some votes for fibrous dysplasia, brown fat. So excellent. So let's move on. So this is kind of alluding to the next talk that I believe is coming up in the series on performing image-guided biopsies. But if you had to click on which approach you would take to biopsy this lesion, what would you select? All right, awesome. So we have votes for a lot of them. It seems like the lateral approach and the posterior approach are kind of winning, but definitely a lot of votes for both of those. So again, something we will discuss further at the end. So this was the biopsy approach that was taken by myself. All right. And so this case ended up being, well, what the path actually came back as was fibrous dysplasia. But as you know, Dr. Fayad, of course, has continued to teach me even after fellowship. You know, if you go back to the original article on liposclerosing myxofibrous tumor, they actually describe it as a lesion comprised of areas of fat, potentially with some, you know, degeneration or necrosis in it, areas of fibrous dysplasia, areas of osteosclerosis. And that's how the people from ARP originally described the lesion of liposclerosing myxofibrous tumor. Interestingly, so I tried to put my needle in the part of this lesion that displayed FDG activity, which so happened to be the ground glassy looking component, if you guys noticed that on the CT, which is kind of a buzzword for fibrous dysplasia. So I suspect that's why the path came back as it was, although if you guys take a look at the article or Google liposclerosing myxofibrous tumor, that radiograph is basically, that's what it looks like. Although, of course, you know, the oncologist with a new FDG avid lesion, of course, they really, you know, wanted to do the biopsy, of course, but if that lesion came across just in your stack of radiographs without a history of cancer, you would be, I think Dr. Fayad would probably agree with me, you'd be pretty confident in reading it as probably LSMFT, maybe one of those other entities, which, you know, as I've noted here, are really the most common entities that you are included in your differential diagnosis for a sort of a lucent or mixed lucent lesion in the femoral neck. That's the first question. I thought that maybe it's not really the right spot for giant cell tumor, which is usually closer to the end of bone, and giant cell tumor is usually fully lucent. And then what I showed with the biopsy image is, you know, you should have sort of this anatomic rationale for how you're performing your biopsy. And if you're not sure, definitely reach out to your orthopedic oncologist to determine what they prefer. In the femoral neck, this inferolateral approach avoids contaminating the joint. If it is this is usually more relevant for primary bone tumors than it is metastases, but still, you know, to have something to guide you is always useful. So avoids contaminating the joint with tumor, also avoids the neurovascular structures, which can complicate either the posterior anterior approach, depending on the position, as well as the greater trochanteric bursa, which can cause the patient a fair bit of pain and things like that if you violate that. And this article down at the bottom, anatomically based guidelines for core needle biopsy of bone tumors, implications for limb-sparing surgery for radiographics, is an excellent primer on all this stuff that I still reference when I'm doing a procedure like that. And if you take a look, it'll probably help prepare you for the next rec talk. Any questions about this case?
So I don't see any questions in the chat, but I'll give a quick comment here. So what could we do to help with the diagnosis of this entity is if you had an MRI or a CT scan, which you did here, if you look at the soft tissue windows and if you can make out some lipid content, because this lesion has fibrous, lipomatous, and cystic content. So if you can make out some lipomatous content, that would help you arrive at this diagnosis, I think, quite comfortably. So something else to think about. Okay, another question is in the chat here. Are there any muscular planes that you should avoid while doing such a biopsy if there is concern for seeding?
So for example, in the thigh, the big one that I always think about is rectus femoris. Rectus femoris is a big no-no to put your needle through because it spans two joints and it really affects the type of surgery that they can do if they have to resect the rectus femoris. That's an excellent point asked by that question, because what that question is getting at is that what the ortho-oncs often do is resect the tract if you're talking about a primary bone lesion, usually they often resect the track of, through which you did your biopsy as part of because of this theoretical concern of seeding. So that would be the one that I would think of in that location, would be, if at all possible, avoiding rectus femoris. And that's just an example. Like I say, there are articles written that talk about all these various things, but that's what I would say in that region.
I think it's also really important to communicate with the orthopedic oncologist directly and before each biopsy. So plan the tract with them, and then you'll never make a mistake.
All right. So next case, 41-year-old male with metastatic melanoma for a staging PET CT. And I will direct your attention here to this kind of mildly increased area of activity that's a little bit asymmetric to the other side, sort of along the medial acetabulum. And the point of showing the CT is that we don't see really much of a CT correlate. So obviously then what was obtained next was an MRI to see if we could determine what was going on with this lesion. And so I've given you some T1 images in multiple planes and an axial T2 FATSAT. So you can sort of digest that for a minute and compare it to the other side and all that sort of stuff. Okay. So far, what's in our differential? All right. So I see, obviously, we have a lot of people saying Mets. And then we've got some votes for trauma, desmoid, lipoma, red marrow. So excellent thoughts we'll discuss further. What do you think would be next most helpful sequence to obtain to sort of help sort this out? The bars are fighting between post-contrast and chemical shift imaging. Now we have a few votes for DWI as well. Okay. So here's the post-contrast. There's the features of the lesion on the contrast imaging. So sort of digest that. Here are the features on DWI. Okay. Here are the features on chemical shift imaging. All right. So what do you guys think? What should we do now? All right. So most people are saying red marrow, do not touch. And that's what I thought too. And, now I guess I can't prove it. So I hope that because we didn't actually do a biopsy of this, I'm hoping that the 86% of you who agreed with me, that we were all right together. But this is a common conundrum in MSK radiology, sorting out red marrow from other stuff. requires you to know the normal marrow evolution from red to yellow. So, when you're born, you're a child, you have mostly red marrow, and then beginning from distally in the phalanges, and then to the diaphyses of long bones toward the metaphyses, as well as the epiphyses, the marrow converts from red marrow to yellow marrow. And then till an adult, it's mostly left in your proximal metaphyses, and the majority is in the axial skeleton. So the imaging features are that it's T1, iso intense-ish, but darker than the surrounding fatty marrow, a little bit hyper intense, very minimal enhancement, which is what we saw here. And the other point that I want to bring in here is one of the advanced imaging techniques of chemical shift imaging. The physics is above the scope of this talk for now, but basically based on the differences in precession frequency between fat and water in the same voxel that results in their signal canceling if you do have fat and water in the same voxel. The number that's been described as a 20% decrease in signal between the in and out of phase images. So if you lose greater than 20% of the signal from the in compared to the out of phase, and that suggests that you're not dealing with a marrow replacing process. And if you don't lose that signal, it suggests that you are. The numbers are a little, it's actually, I think it's been described as like 18% at 1.5 T and 25% at 3 T, but 20% is kind of what people use. And then, just a technical point, you have to make sure that the out of phase images were done first, because there's T2 star effects, aka, sort of susceptibility. And so if you did the out of phase after the in phase and that you lost signal, you wouldn't really know whether it was because of true, fat in the voxel, fat and water mixed in the voxel, or was it some susceptibility artifact from something else? So hopefully this illustrates how we sort of sort through this common conundrum in looking at bones. Questions?
Yeah, I think this is actually a very challenging topic, marrow imaging in general, marrow evaluation, especially in children who already have a lot of very dense red marrow that's packed in. It's often quite challenging to separate that out from tumor. So this is a very useful technique, and it's very fast. It requires no contrast. And as you said, it's really, it has very high sensitivity and specificity if protocoled correctly up front. Okay, we have a question. How do you check whether out of phase is done first?
So I guess first I should explain that. Thank you for asking that. First means with a shorter TE. Not literally not whether it's done literally first as in the acquisition, that doesn't matter. It's actually whether the TE, and so what Dr. Fayad alluded to is this, it has to be done correctly, right? So the out of phase actually has to have a TE that's approximately half of what the in phase images have. And so what you need to check is in your little, box in the corner of the PACS, it shows you your TE of the sequence. You need to make sure that the out of phase image has a TE that's about half of what the in phase image has, because the TE determines how much of that T2 star susceptibility type artifact you're getting in the image, or T2 star decay, I should say, which is beyond susceptibility, of course. But yeah, so the TE of the out of phase needs to be shorter than the TE of in phase is probably a better way that I should have said it on the slide.
Okay,
all right.
No more questions.
All right, move on. Next case, adolescent young adult male with insidious onset of pain. So here are some radiographs. They don't show up the best, I'm sorry. So then we have a lateral that hopefully in combination with those preceding, you can find a finding. See some dots dropping down, that's good. Excellent. So everyone's seeing it. So we'll move on here. Here's the CT appearance for what that's worth. MR appearance, T1 and T2 fat sat showing you some of the salient features of this lesion. So what kind of differential you guys come up with based on what we've got so far? Okay, awesome. So I like all the choices you guys are coming up with: giant cell tumor, aneurysmal bone cyst, and chondroma, bone cyst, chondrosarcoma, interosseous. I didn't really realize that Pull Everywhere likes to shuffle around the words quite so much. So it's a little hard to see some of them. I also saw a chondroblastoma come up in the chat, popped up and showed me. So let's move on. So we have another slice of the T2 fat sat, as well as post-contrast fat suppressed image showing a feature that I think is important. So see if you can decide what that is as well. And in a corollary to that, I've given you a delayed subtracted post-contrast image. And which of the following is not in your differential based on this image? Okay, so most of the votes go to giant cell tumor, followed by primary ABC. So we'll talk about that. All right, a few more images here. We have an arterial phase subtracted post-contrast image, delayed, and then just sort of an axial, just T1 fat sat post showing you another look at the lesion. So this was biopsied and turned out to be a chondroblastoma. So a couple of important things here. What I was mostly showing in the image, in the images, was that was a small solid enhancing component associated with that lesion. So I think many of you correctly identified the air fluid level, or the fluid levels in the lesion, which makes you think of ABC. But ABC itself should not have any solid component. And because ABC can arise secondarily from multiple additional lesions, such as giant cell tumors, chondroblastoma, as in this case, from very commonly actually with chondroblastoma, as I've said here, about 80% of them in one study had a secondary ABC. A telangiectatic osteosarcoma, it also classically has these fluid levels. So if you see any solid component, you have to question the diagnosis of primary ABC. The other features that this lesion had that are actually relatively common for chondroblastoma are it did have a good degree of perilesional edema around it. And a joint effusion associated with it, which, primary ABC, I would think that to be less likely. And chondroblastoma itself, as I've got on the slide there, is a rare benign bone tumor, mostly male predominance, 3 to 2, and second decade of life, which fits with this case. And it's an epiphyseal lesion. The calcaneus and talus are most common after the long bones. And it's expansile lytic. About half of them are mineralized, and like I said, about 80% of them will have a secondary ABC component. All right, any questions?
Okay, while we're waiting, oh, there we go. Here's the question in the chat. How do you get a good biopsy sample of lesions that have cystic components?
Yeah, that can be, it's definitely challenging. And if I had a one size fits all answer, I probably would have developed a device or written a paper about it. But I think the important thing there that hopefully you saw in the CT image was that the needle was targeted very well towards the solid component itself. Most people use some component of a drill. We use the on-control drill primarily, my institution. So really trying to get where it is actually a solid component, because you're absolutely right. If you are trying to drill through a cystic component or something in the bone, you end up just getting nothing, in your needle. So I think that the best piece of advice I could give is to, when you're looking at something like this that has a solid component, is to go for the solid component. And if it doesn't, you may be stuck trying to get the edges of the lesion, try to get your needle all the way through, get a piece like proximally and distally through the lesion. If it's a purely more cystic type lesion, or biopsying, if it has like perilesional enhancement or something in the bone or marrow replacement, trying to biopsy that, if it has that around it, trying to biopsy that component rather than the cystic component. But
okay, 2 more questions, Dr. Jones. So one is, could this be a giant cell tumor based on imaging?
I think it's one of those things that it was in the end of the bone. It does have this sort of intermediate signal solid component. So, theoretically, and like I say, GCT is one of the lesions where secondary ABC comes up. So, I don't know that it's the best look for it necessarily. Maybe I'm sure Dr. Fayad has seen more of these with secondary ABCs than I probably have, but I think technically, based on the features, theoretically it could be.
I think that's a good answer. Another differential I would put in here is osteoblastoma. That's another one that has perilesional edema, secondary ABC, and so on, some aggressive features. Okay, another question is, does the presence of enhancement clue you into secondary ABC?
Yeah, ABC itself should really, like I said, there shouldn't be anything that looks like a solid enhancement. Let me flip back just so you can see. Hopefully I don't screw things up here. Yeah, you see this component, you see this little wedge of stuff that's sort of filling in on the delayed. That's really, you should not have a blob of enhancement in an ABC. You can have sort of peripheral and lobular septal type enhancement in an ABC around the little chamber things in it, around the little locules, but having sort of a blob, a two-dimensional, three-dimensional blob of enhancement shouldn't really be something that you're seeing with a pure ABC.
Okay, and just since we're on this particular slide that shows arterial subtraction and delayed subtraction, can you just explain how you use these 2 features?
Yeah, so, and I think it'll come up in one of the other cases, but, the arterial phase really, lesions that are, let me back up and say that using the phase of enhancement, as you guys may be familiar with from, say, doing breast MRI or other things like that, or liver MRI, for instance, is helpful in trying to tell you something about the aggressiveness or possible malignant potential of the lesion. So a lesion that enhances avidly in the arterial phase has to raise your suspicion a little bit more than a lesion that is more of a progressive or delayed type enhancement, which this lesion was. You see that there really isn't much at all on the arterial, but it fills in on the delayed phase. So that's typically the way that it's used.
Okay, thank you. We'll move on.
All right. So elderly female, prepatellar bursitis, unresolved with conservative therapy. So I'm showing you a series of radiographs immediately post-operative, and then 2 years prior to her presentation, 1 year prior to her presentation. Hopefully you see some features that you would comment on. So click on anything that looks abnormal. Okay, excellent. Everybody's arrows are okay. I like that somebody clicked on the vascular. Gosh, that's nice. I like that. But obviously the arrows are dropping all over this sort of lucent area there. So that is excellent. But yes, the vascular calcifications are indeed abnormal. That is true. I cannot disagree with you. So frontal and lateral here is showing you better this lucency here that, by the arrows, and then lucency all around the tibial component and this focal area where the soft tissues are sort of prominent here anteriorly. So what do you guys think? So you guys definitely mentioned all the things, or so many things that you should definitely be the first things on your differential diagnosis. But you did forget this is the tumor conference. So let's move on and say, somebody got malignancy here. Let's see where we go. All right, so I have here some Maverick sequences, which we'll talk about a little bit more at the end if you're not familiar with them. But we have a PD type sequence and a fluid sensitive sequence here of the arthroplasty. And here's some T1 post contrast in the middle, and then fluid sensitive sequence here. All right, so obviously, many of you said loosening, which is true, it's loose, but why? What's the cause? I gave it away by reminding you all that it was a tumor conference, didn't I? That's okay. So obviously the 94% of you, now 100% who said neoplasm, are right. Infection is very valid. I mean, I think this is a very, very uncommon thing to have happen. So all the other stuff that you would have said, I would have said first as well, if it didn't come to me as more of like a already established sort of thing. But so people have described osteosarcoma as sort of a rare quote unquote complication of an arthroplasty, but it's more likely to be just a coincidence or just some altered healing related to it, because it's not something that's routinely described as a complication when the orthopedic surgeons are talking to patients about getting an arthroplasty. They're not listing off, yeah, you could die during surgery and it could get loose and you could get an osteosarcoma. That's not really how they're talking about it, because it's incredibly rare, and it's probably just a coincidence because many people who get osteosarcomas are older, and the location in the bone, can be kind of similar to where an arthroplasty is going to be. Obviously, as illustrated by this case, it can present similarly to other forms of loosening. Just briefly, I wanted to mention Maverick and CMAC. So Maverick is what we have at my institution. It's the GE version. CMAC is the Siemens version of an advanced metal artifact reduction technique. Again, the physics is beyond the level of this and probably beyond me as well, but they both, suffice it to say that they both excel at demonstrating the bone implant interface, which, as you know, from even what we call quote unquote Mars, doesn't always show you that well due to the artifact around the implant. So these really help you with getting as close as you can get on MR to looking at the sort of bone implant interface. This osteosarcoma, for what it's worth, turned out to be a fibroblastic osteosarcoma, which accounts for about 25% of these. All right. Any questions?
So Blake, perhaps you can just review how did you know this was osteosarcoma and not loosening or pseudotumor?
So interestingly enough, so what actually happened is that it was felt to be that the patient, as I said, the history was unresolving prepatellar bursitis. So what happened is somebody said, well, you know what, we're just going to resect that prepatellar bursa. And when they did so, as you can see from these axial images here, the lesion was actually exhibiting soft tissue extension, and there's other images that don't show it as that show it better that I don't have here. But basically, the lesion was kind of wrapping around the patellar tendon, and so what happened was that a resection of this bursa was attempted, and the path was high-grade sarcoma. So that's how we knew in real life. Although, I think the sort of, if you didn't have that type of history, the enhancement to me is a little bit too solid of that. Although, you can get enhancement and sort of even a thick rim with like adverse local tissue reaction and things like that. But, it's more of a rim with sort of a fluid attenuation center usually. And the lesion also was sort of almost, emanating from the bone. Somebody says, where's the pre-op radiographs? Here, I'll show you. Pre-op radiographs. Yeah, I don't actually have the pre-op. I was thinking post-op. The lesion seemed to be sort of emanating from the bone and wrapping around things and all of that, which usually, like ALTR, is more of a complication that is, from the sort of pseudo capsule rather than, it might involve the bone, but is usually sort of, not doing that as much. I don't know. I don't think that's a very good answer. Maybe you have more to add, Dr. Fayad, but.
No, I agree with you. So pseudo tumor is usually rim enhancing and with a fluid center. It's more like a collection rather than soft tissue enhancement, which is what we saw here. So there's a good question in the chat. Do you do MRI routinely for suspected implant loosening?
It depends on your institution. So in my fellowship, as Dr. Fayad can attest to, we did routinely do MRI for loosening. In my institution, and actually what the ACR, the appropriateness criteria still say CT and bone scan. And I think that's because of the wider availability of that thing. So, Maverick, CMAC, these like advanced, I don't even think they are actually on other manufacturers. It's only really GE and Siemens. And there are additional software packages, that require specialized expertise from the techs to do, and an interpretation. And obviously additional costs and all that. We only actually have it on one scanner in my institution, so the availability is limited. And so that is still doing this sort of CT bone scan combo, it is still recommended by the ACR in the appropriateness criteria. But, in an ideal world where everybody had all the most advanced equipment, MR is actually wonderful for it, because it shows you not only the bone, the soft tissue complications, it can show you the bone, bone complications as well in sort of a one-stop shop rather than having to have multiple studies for it. So.
Okay, we're pretty much out of time. There was two questions about the radiograph. One was that on the 2-year radiograph prior to presentation, there appears to be some periprosthetic lucency. Would it be reasonable to have suggested loosening infection? And the other question was, did the soft tissue component show any osteoid matrix on the radiograph? So I don't know if you can page back.
Yeah, I can. So for this lateral kind of would be the best. I don't think it really did. I think it's really hard to show any osteoid matrix. I mean, maybe some of these little, again, on this screen, it's not the best either. Maybe some of these little blobs in here were some osteoid. And yeah, I think it, would definitely be reasonable to have suggested it at that time. On that 2-year post-op radiograph, definitely represented a change from the immediate post-op images.
And probably the patient, if this was really osteosarcoma, should have started to have symptoms by then and would have gone on to cross-sectional imaging, and we probably would have detected it at that stage. But if the person like with loosening, sometimes you don't necessarily have symptoms when you have lucency on the radiograph, and in which case the we wouldn't go on to cross-sectional imaging necessarily. Okay, so I believe we're out of time. And I want to thank everyone for joining us today. This, as we says, we're going to have another SSR webinar in February coming up regarding image-guided biopsies. And I do want to remind everyone to please fill out the survey that will be either emailed to you or put in the chat shortly. Okay, thank you very much. Have a good night.
Thank you all.